Index pillar push for C1, C2 rotation or lateral flexion. All right, there's my contact right along C1. Nice tissue pull up onto the posterior arch. For rotation, again, I make sure I have the head with both hands. For pure rotation, I rotate, I get in close, and it's going to be HVLA with both hands. For lateral flexion, tissue pull can come the other way, from front to back, isolate C1, C2, and the thrust is just going to be, in this case, from left to right. Or you can combine the two. Lateral flex, rotate, and your thrust will be right from there, okay? So from here, we're going to do a few occipital adjustments, right? So for COC1, we've got lateral flexion, rotation, anterior sagittal glide. We can perform all those from this position. Use a thenar or a hypothenar contact. Let's do the traditional hypothenar occiput for lateral flexion and rotation, all right? So I take my hypothenar, I place it right on the occiput behind the mastoid, and I let the rest of my hand contact the head. The other hand supports the head. I've got good control of the head. Laterally bend at COC1, rotate, and my vector in this case is straight across. It's a break for combined rotation, lateral flexion, COC1. Another alternative to that is to use the thenar. And if I'm using the thenar, I'm going to come up a little higher on the occiput. So there's my thenar contact right above above and behind the ear. The other hand is going to sandwich the head between both. My head will be sandwiched between both hands. My fingers are pointing down towards the floor. I retract a little bit. I laterally bend to the same side. I rotate the nose back to the midline, just like the assessment. And again, the adjustment is, in this case, from left to right and a little bit towards the opposite shoulder to give me that anterior sagittal glide. That's an effective COC1 adjustment as well. And then we have some supine lifts that we can do. So I'm going to show the lift from the right side of the patient. I think the camera will see this. I'm going to use my forearm to capture the side of the head. My fingers are going to wrap around the chin. The head will be resting on my forearm. So there's what that looks like. All right? And it's coming right along the zygoma on the downside. Right? Headpiece is elevated a little bit. That's going to give me some right lateral flexion. You comfortable? Mm-hmm. All right. I'm holding the jaw, but I'm not going to thrust on the jaw because I don't want to create any movement in the TMJ. The contact is going to be right up along the mastoid process. My forearm is in the middle. All right. So this adjustment is actually a lift. All right. It's not this. All right. The thrust is straight forward along the plane of the headpiece of the table. All right. So there's my contacts. I'm not thrusting into rotation, although I'm not giving up any rotation either. So I'm relaxed. Is it right to just do a mock thrust here, just to show this? I'm relaxed, contacts in place, and I just add the thrust in from that position. From that very relaxed position, that gives you the HVLA. All right. COC1, a seated lift. All right. There's a variety of different ways to do this. All right. The first method is to just take your index contact and place it alongside the occiput. The ear will always end up in this thumb-index web when you're doing this properly, just like you see it right there. All right. The preload for this is lateral flexion over the contact, and once you attain that lateral flexion, you're not going to get a lot of rotation. All right. The thenar is up against the jaw, but because my index finger and my middle finger, my index finger are on the occiput, it's one unit. So I'm moving the mandible and the occiput together. So as long as you maintain those two contacts together, you'll never pull on the mandible, which you don't want to do with these adjustments. Sometimes when you set these up on yourselves, you might notice that your doctor's pulling on your jaw. So that means they're not really making a good firm contact on the occiput. You ask your patient to hold their head there. The other hand is going to come around, hand open up wide, and point the fingers towards the floor as best as you can. And place the ear right in the center. Right? You're going to position yourself so that you're parallel to the plane of the face. Right? It's not a rotary move. It's not this. Right? What it is a break towards you, right? While you're maintaining this position of lateral flexion and rotation. All right? I'm not going to thrust on this because we pretty much adjusted this area up pretty good, but the thrust is a thrust towards you. So you want to start off very relaxed, very, very comfortable, so that you have something to thrust with. All right? The other version of this move is to, instead of using your hand on the side of the head, you can use your chest as the lift, right, as the auxiliary contact. The contact on the occiput is exactly the same, comes around, right? But instead of doing this and placing the hand on the side, what we're going to do is we're going to put the patient's head over here. So let's start that again. I'm going to make my contact along the occiput. I'm going to position my chest parallel to the face. I'm going to have to lean over to get that onto my chest. And the camera can't see it, but I'm up on my tippy toes a bit because this stool's kind of high for me. And then the adjustment is connecting the patient to you and lifting at the same time. Right? So it's up and lift. All right? You don't want to thrust too much with the contact hands because they're up against your chest. There's nowhere to go. So the adjustment really comes from the legs, giving you the lift. All right. We can also do a middle finger C1, C2 posterior arch pull in the seated position. Swing towards me a little bit. The contact is same way we did the other cervicals, right? You can use a similar contact for the auxiliary hand if you like, or if you prefer, you can just point your fingers backwards, hold on to the center of the head. You can do this for rotation C1, C2. You can do it for lateral flexion C1, C2, or you can combine the two movements at C1, C2 as well. This next adjustment is a Zygoma contact. I believe you guys have done this adjustment already. You know this one. However, I'm just going to kind of put some nuances into it to set up for you, okay? I like to think of it as a choreographed move. In other words, if you do it the same way every time, you'll be very consistent with it. So let me show you what the auxiliary hand does first, right? The auxiliary hand, if you open the hand up wide as you can make it, and you picture this like a line, right? Let's say point A, point B, right? Picture a line created by your thumb thenar. And you place that line perpendicular to a line that would go across the eyes, right? About 1 finger's width behind the eyes. That's your auxiliary hand, fingers pointing down, and you let the hand fall the rest of the way over the head and face, right? And neck. And then you put that side down. Right. The next contact is the thenar and the zygoma. And you're going to set this up in such a way that you come from above and you point your thumb down the jawline. Just like that. Now this is actually an assessment. Right? We can use this to assess, in this case, right lateral flexion and left rotation at the upper cervical spine. Right? But the adjustment is right here as well. All right. So for the adjustment, you just follow through with HVLA. It's almost like a punch, but you're not really punching the patient. You're lightly making your contacts, and you follow through with the hand on the zygoma. The bottom hand is catching the thrust. Right? It's not pulling up. It's not lifting cephalward. It's just there to create the fulcrum for you. These fingers are wrapped around the occiput, right? And it's creating that fulcrum. You're going to be gapping that downside, approximating the upside. So that's a thenar zygoma contact. This last seated adjustment is, it's the last one on the list. It's a seated thenar occiput for coupled lateral flexion rotation anterior sagittal glide. This is a nice adjustment as an alternative to the supine adjustments we were doing. It's actually, we did this adjustment supine, we're just bringing it to the seated position. So the thenar is going to make a contact on the occiput right above the mastoid. And I'm going to come down on the mastoid occipital area with my contact like that. My fingers are going to be pointing back towards me. All right? The camera won't be able to see this. Actually, let's turn you around so the camera can see this. The other contact's going to be right here. All right, I'm just going to maximize my contact. My thenar is going to be on the zygoma. My fingers are going to be pointing back towards me. All right? This is what the auxiliary contact's going to look like. So swing back around again. All right, a little bit further. All right. So there's my contact coming down on the mastoid. All right. And you can see I've got good control of the head. All right. Good control of the head. I retract, step to the left a little bit in this case. I laterally bend to the left, rotate the nose back to the midline, and the thrust is a break towards the right shoulder, right front of the right shoulder.